My name is Niamh Fitzgerald. I am a research fellow from the Institute of Social Marketing and Health at the University of Stirling, and I'm going to be chairing the second session for you today. And this second session is all about the international perspective and learning about policy development and monitoring. And just before we start, I obviously want to say thanks to the HRB for organising today and putting together such a fascinating programme. We've got 3 great presentations in this session. So the first one, I would like to introduce our first speakers, who are Mary Dunn and Maria Nelson from the HRB, who are going to be talking about advancing alcohol research in Ireland and how to stay up to date. So a little bit of a bio about our speakers. Mary Dunn is a Chartered Information Specialist in the HRB National Drugs Library. Principal interest is enabling the use of evidence in decision-making. Presented at numerous conferences and has authored articles for the library and drug-related publications. She was elected to the Register of the Chartered Institute of Information and Library Professionals in 2015 and the Register of Associate Members of Library Associations of Ireland in 2016. Her qualifications include a Master's in Psychology and a Master's in Information and Library Studies. And she's going to be presenting with Maria Nelson, who's also a Chartered Information Officer at the HRB National Drugs Library, a position that she's held since 2010. Maria's professional interests include social media as a dissemination tool and library impact. She's written articles and presented at many conferences and has a master's degree in applied social research from Trinity College Dublin. So Maria and Mary, the platform is all yours.
Thanks, Aidan. Hi. So today Maria and I are going to tell you about our collection and some of the resources that we have that can help you stay up to date with alcohol research in Ireland and also internationally. But to start, consider for a moment what comes to mind when you think about a library. Books, perhaps. Did you think about your local public library or maybe an academic one? You may have even thought about the librarians who manage them. Now, we know we have a certain stereotype. But the truth is that we come from an important ancient tradition. In terms of health librarians, medical papyri have been found dating back 4,000 years. In ancient Egypt, probably the most complete and best organized medical collection was found at the Temple of Thoth. Now, Thoth was an Egyptian god and patron of writing, scribes, secrets, and knowledge. And as you can see, librarian titles evoked images of life and magic. And hopefully, Maria and I in the Drugs Library are continuing that magical tradition. So why do we have a specialist digital library focusing on alcohol and other drugs? Well, we're about providing access to evidence. We aim to enable evidence-informed decision-making for everyone, including those who use alcohol, those concerned about alcohol use for themselves or others, educators, practitioners, researchers, and policymakers. We were set up in 2002 by those who recognized that there's a great deal of information related to the drug situation in Ireland. But this was largely invisible, scattered across many sources, and often behind a paywall. And the increased use of the internet since then has not improved the situation. Because although big search engines will bring you back lots of results, they only scratch the surface of what is being produced, particularly by community-based organizations. And of course, sponsorship and unknown algorithms influence the top results. We also know that alcohol issues are found in a wide range of sources. So obviously in the literature on substance use and addiction, but also in the literature on physical and mental health, suicide, trauma, homelessness, deprivation, education, crime and justice, economics, social care, and so much more. So we in the Drugs Library want to systematically capture this information and make it available in one place. So although our primary remit is to collect Irish-related sources, we realized that people need access to a wider perspective. So we also collect key international research. Though due to potential cost implications of purchasing material, we only add international information if it's freely available. So we have a huge amount of valuable information available. In fact, about 25,000 items in our collection. How do you access it? Well, through our website at drugsandalcohol.ie. I'm sure some of you are familiar with that. On our homepage, we provide some short instructional videos about using our site that you can explore in your own time, so you don't need to take notes now. Today, we're going to have a quick look at how our resources and services can help you stay up to date. And there are two main options for this. You can search or browse. So let's start by going to our advanced search page. Now you can see there are many different options to choose from. And as mentioned, there is a video that goes through how to get the most out of this search. One useful option I'm going to speak about today is subject. So these are like keywords. You'll have heard of the Dewey Decimal System used in many libraries, but we use a special system based on alcohol and other drugs. And we tag each item with subjects from this classification system. And I'm sure it's of no surprise to anyone here that alcohol is the most commonly tagged drug in our collection. So this is just the top level. You can click on each of these headings to see the level below. So for example, if we clicked on policy, planning, and related concepts, it shows me the subjects underneath this. And if these have sublevels, I can see those, and so on. Now, the reason I mention this is because using subjects is perhaps the easiest way to find items in our collection. And if you want to explore them further, there's a link to these lists on the search page. So we'll take an example. If you're interested in alcohol and marketing, as been mentioned earlier today, you could click that link and see all the 700 plus items we have on marketing. But that includes all substances. So let's go back to the search page. Our advice is to keep things simple. Start with one or two words and see what we have. So we can just enter the term marketing, and we want to restrict it to alcohol. So we add that too and click search. And that would bring back 446 results, with the most recent ones first. So if that's too much, or not what you expected, you can refine your results. So you could add more subjects, such as Scotland, or youth, or sponsorship. You could limit your results by putting in a date range. You could click certain item types, so articles and reports, or perhaps you just want to see videos about a topic. You could limit your results to Irish or international related research, or to view only peer-reviewed articles, reviews, or guidelines. So for our example, I just ticked peer-reviewed articles in the last 5 years. And that restricts our selection to those criteria. So if you create the perfect search in an area of interest and are logged into our website, you can save your search, so that the next time you come to our site and go into your account, you can quickly view and rerun it. And when saving your search, you can choose to be notified by email if we add something to our collection that matches your criteria. And that's a really easy way of staying up to date. So that's a bit about search. And now to browse with Maria.
So on the home page and the blue area of every web page, you can see some of our main resources, including the Key Irish Data Resource. This resource draws together some of the most important data for Ireland. Each of the images is a link to a web page, and I'll briefly go through each of these pages, starting with the fact sheets. These fact sheets pull together the most important Irish data on specific drugs, including alcohol, on young people and gambling. There are currently 10 National Library fact sheets. Sections include data on use in Ireland, treatment, mortality, crime, and so on. The references provide a useful list of key documents. We regularly update the fact sheets with new data, so you can check out these for Irish information. Now, moving on to the next page in this resource, regional data. We recently developed regional fact sheets which include data on use and treatment. You can click on the interactive map or on the area link so you can see data for your area. Our colleague Anne Doyle has produced a fact sheet with alcohol data by county that is also available here. The next option on the Key Irish Data resource is prevalence. Now, each of these headings open up to reveal links to key studies on alcohol and other drug use, including the National Drug and Alcohol Survey, Healthy Ireland, SBAD school surveys, and so much more. The treatment webpage gives you access to the latest treatment data for Ireland from the HRB's National Drug Treatment Reporting System. You can click on the bulletin for alcohol, or you can click on the treatment data tables. Now, with these, you can create your own tables. You can choose alcohol and then your years of interest, age range, treatment status, and gender. I'll just give you a chance to look at the different variables. You can also choose specific variables such as highest education level, employment status, frequency of use, and more. And finally, you can choose to show your results for the whole country or by region. So this is just an example for you. So I selected all cases in treatment for alcohol as the primary drug and chose living with whom. Now, this level of detail may be important to those who are researching, planning, or implementing interventions. And you can also view your tables as graphs, which provides a nice visual breakdown of the data. You can also view your tables as pie charts with percentages. Now, this graph shows the employment status for those in treatment with alcohol as their primary drug. Now, we're currently testing the 22 data, and this will go live in the coming weeks. So that was the interactive tables on the treatment data page, and it's a really useful resource. Moving on. The deaths webpage has the most recent data from the HRB's National Drug-Related Deaths Index. Now, due to issues collecting data during COVID-19, there have been delays publishing recent figures for alcohol, but we'll add everything new to this page. In the library, we produce a monthly electronic newsletter with links to all the new publications, Parliament debates, and news stories that we have added in the previous month. Scanning through this is a great way to see what's new. We also produce DrugNet Ireland, which are on the tables there in front of you. And this is a quarterly newsletter produced by the Health Research Board. And the articles summarise all the latest Irish policy and research. So again, it's a really easy way of keeping up to date. and you can sign up for both these newsletters through the links here. Finally, we wanted those particularly interested in alcohol to have resources. Oh, did I miss a page? Sorry. Next, the national report, and this is submitted annually to the EMCDDA, the European Drugs Agency, and this focuses on illicit drugs, but also does contain some references to alcohol. Then the policy reports page, and this has links to current, past strategies and other policy resources. Now, finally, we wanted those particularly interested in alcohol to have resources that give quick links to useful documents and save searches. So we have 2 web pages, one for alcohol policy and one for alcohol research. The alcohol policy webpage provides links to some key documents, then links to searches that we have done for alcohol and the subjects you can see on the screen. The 12 blue icons on the lower part of the page are first presented, limiting the search to Ireland. And then they are repeated, given access to all research. On the alcohol research page, again we have some key documents and then quick links to the fact sheet, treatment data page and some save searches. The map provides a link to a regional data page with Anne's recent county level fact sheet. And just like the alcohol policy page, the icons first limit the search to Ireland and are then repeated for all research. So that was a very quick overview of the key Irish data resource, and there are many other resources, notably our practitioner resource, available on our website. So take a look through and see the elements that may be of use to you. So, in summary, libraries like ours are not about books and buildings. We are about providing quick and easy access to evidence. Specifically, we want to empower through evidence so that people can make informed decisions in relation to alcohol and other drugs. So we have more to tell you, but our main message today is to come and explore what is available on our website. We'll take questions at the panel discussion, but that's all from Mary and me, the women of the Magic Library.
Thank you very much to both Maria and Mary, because I think in a world where there's more information than anybody could ever fit in their head, we're internally indebted to the information specialists for keeping us right on the best quality evidence and the latest evidence as well. So a call to action and some homework for us all to bookmark all of those pages. Right, I'd like to introduce our next speaker. Our next speaker is Professor Niamh Fitzgerald, who's going to be talking about building capacity for alcohol research and monitoring in Ireland. So Niamh is a professor of alcohol policy at and the director of the Institute of Social Marketing and Health at the University of Stirling. She's also the deputy director of Spectrum Research Consortium with responsibility for impact, knowledge exchange and public engagement. So Niamh specialises in mixed methods alcohol policy research with interest in retail premises licensing, minimum unit pricing, framing and public communication of alcohol, as well as managing commercial interactions. So Niamh is recognised internationally for her work on alcohol brief interventions and has advised WHO Europe, Public Health Scotland and several European governments. Niamh originally trained as a pharmacist at Trinity College here in Dublin and was awarded her PhD in 2003 by Robert Gordon University in Aberdeen. She has served on the Public Health Alcohol Research Group, which was appointed by the Minister for Health in Ireland, and is the lead author of a report produced by that group to guide the monitoring and evaluation of the Public Health Alcohol Act. And she also co-led the UK-Ireland Alcohol Research Network. So please join me in welcoming Niamh to the stage.
You don't always know when you're submitting your biography that it's going to be read out in full. Thank you so much for that, Nathan, and thank you for the invitation and for having me. Just waiting on the slide coming up now, but I'm going to talk about building capacity for alcohol research, but I'm going to focus specifically on building capacity for alcohol policy research and research that's necessary for advancing policy. And I think that's really key, and I think it's really key in Ireland when we look at the most effective measures. They are measures that usually require legislation, and so making sure that we have that capacity is key. So, if my slide is coming, thank you, and we can go to the next one. Super. So, and I've got a clicker as well. Why do we need alcohol policy research? Well, I mean, I think probably some of the speakers this morning have already talked about this, but I was struck by a quote from Richard Bruton in the Irish Times recently. He spent 42 years in the Dáil, and he's saying that politics is much more about emotion than it is about evaluating evidence. So I thought I'd start just by saying, why do we need alcohol policy research? And I think we need research because scientific evidence makes for better policy, but I'm not naive to think that it is the only thing that dictates policy, and I don't even think it should be the only thing that dictates policy. But I think right across these kind of 4 stages of the policy-making process, scientific evidence has a really key role to play. So, you know, whether you're sort of trying to define what the problem is and make a case for action, whether you're trying to sort of predict or plan what the actions might be that you're taking, whether you want to understand the impact of actions that have already been taken, or whether you want to better understand the process by which those policies are made or influenced, there's a role for scientific research across that. And I suppose one of the things that I think Anne mentioned this morning was just how interesting it is to work in alcohol research, because it does cut across a lot of scientific areas. And I think when we think about building capacity, we need to think beyond public health. When we look at what evidence makes a difference in terms of advancing alcohol policy, it's evidence from across multiple different disciplines that we need. And what we see, I think, is often a focus on that first stage around what is the problem. And I think we absolutely need research that is counting how many people have problems, what is the level of problem, and so on. We need the sociology that looks at what's driving those problems, what are the influences in society and in the environment. We need health services research, and we need research around commercial determinants. But I suppose what I'm advocating for in this presentation is that when we do that kind of like, what's the problem? What are the risk factors? What do we see? We should be doing that purposefully. So if we're doing that with a view to saying what policy debate or process is this research going to inform, I think that guides us towards that kind of problem definition research that's more likely to make a difference, rather than maybe just telling us things that are interesting, but maybe don't make the biggest difference in terms of a policy debate that's happening. I'm not going to go through all of these, but I think if I focus on kind of around evaluating policy solutions, I think it's worth saying that there are study designs that go beyond just having the data. So it's, having data is not research. Research is what you do with the data that you have. And so there are technical aspects of building capacity that I don't know whether we have outside of alcohol in Ireland, like time series analysis, controlled time series analysis, being able to do research that allows you to more confidently say that this policy change led to this change in outcome or to this change in trend is a specific field, a natural experiment evaluation where the whole population is exposed. And it's a very different kind of research to randomized controlled trials, and the standards and good practice in that kind of research are very different to clinical research or indeed RCTs, and I'll come back to that a little bit later. But I think, it involves disciplines right across the board. So I'm going to make maybe a slightly laboured metaphor here with the Rugby World Cup. I'm a massive rugby fan. I have tried to make sure there's no alcohol sponsorship in any of the pictures that I've used, and I'm not going to labour it too much actually. But I think the first thing, if you want to win the Alcohol Research World Cup, is that you need innovation, and Ireland clearly has this in abundance in rugby, but also very much in the Public Health Alcohol Act. And if you look at what's in that Act as a piece of legislation, as has been mentioned, there's much more innovation and a wider range of measures that's in there, even in what was in the sort of national strategy that Scotland introduced in 2008, which had several measures, but nothing like the range that is in that Act, which was even more impressive as an actual piece of legislation and not just a strategy. But importantly, I think when you look at the text of that Scottish strategy, it included a commitment to research from the outset. So there is a whole chapter in the strategy on how will we measure success. recognising the importance of a robust evidence base, and talking about establishing what then became MISAS, which some of you may have heard of, which is Monitoring and Evaluating Scotland's Alcohol Strategy. And you'll see here that they talk about the need to consider multiple sources of data and recognise their limitations, and they talk about bringing in expertise about alcohol, but also methodological expertise in research and evaluation. So that commitment to evidence was there from, I would say, the sort of start of what the Scottish Government tried to do. I'm going to give you two examples of what happened in Scotland. So there was a massive programme of investment in alcohol brief interventions, so short conversations about alcohol between professionals and the public. Those are expensive to make happen. If you want to really make them happen, you have to train people, you have to invest, and they invested about 80 million in that programme and subsequently another 40 million. And there was some excellent qualitative studies that were done on process and implementation. But when we do a review of that programme now, sort of 15, 16 years later, and I think about the questions that we need to answer internationally to be able to understand how should people have these conversations with the public about alcohol, the Scottish programme has not moved us any further forward at all in the answers to those questions. And that's a big embarrassment, frankly, internationally, when you talk to other researchers who are interested in alcohol brief interventions. There's no legacy of new knowledge or capacity in the system for researching alcohol brief interventions, despite what was a very large programme of investment from the government. So if you contrast that with minimum unit pricing, and for not advocating for delays in public health policy, but there's no doubt that a bit of notice helps research. It allows for research to be more carefully planned, and that can be built into the process. If you know that a policy is coming, you can plan for the research even before it's potentially enacted. Now, minimum unit pricing, as Frank mentioned, cost almost nothing to implement. Arguably, there could have been a bit more investment in supporting vulnerable people, but there was, in contrast, a big investment in research. And I think the level of priority and publicity around the policy also enabled researchers to seek funding from other sources. It wasn't all of the research on minimum pricing wasn't due to direct government investment, and I'm going to talk a little bit more about that. Critically also, kind of perhaps a little bit by accident in terms of the result of it, that there was a happy accident, I think, in terms of the MISAS team deciding to bring everyone who was doing research on minimum unit pricing together regularly. And before the pandemic, that was done in person. And I think those in-person meetings like today are so important in building capacity and building community. And that allowed researchers to kind of go, well, what questions haven't been answered yet? What are you doing? What am I doing? Right, maybe we should get together and we'll see if we can get some funding to do this. And it allowed people to be able to make a really strong case around where the gaps were and what needed to be done. In Ireland, I suppose the equivalent is the Public Health Alcohol Research Group that Helen mentioned. I am a member of the group. And I suppose this was established with very similar aims to what was in Scotland. It was, as Helen mentioned, impeded by COVID-19, but has developed a framework for evaluation, and we await with interest what will happen to the recommendations that were made there. But what I think I can say wouldn't be a surprise to anyone is that the report does include a focus on capacity building in Ireland, given the situation that Anne outlined at the start in terms of kind of the demographics around who's involved in alcohol policy research in Ireland, and how there's a need for kind of greater capacity in that. What do you need for success? Well, you also need an audience for your research. And, it's clear that these three groups on the slide here are all key to that. You need people who recognise the value of research, who are asking for that research, who are calling for that research, and who are respectful of that research. And I think one thing that's been a particular disappointment in Scotland recently is that the Conservative lead on health in the Scottish Parliament referred the Scottish Government report on minimum unit pricing to the National Statistics Agency with a complaint saying that it hadn't been, it wasn't correct. It misrepresented the research. And as a scientist involved in what was probably one of the most robust and carefully done evaluations of a public health policy ever in the world, it was really, really disappointing to see that sort of, I suppose, what I can only assume was an effort to score political points at the expense of undermining science. It's a very short-term move. And so I think, it's respecting the research even if you don't like the findings, and that applies to us as public health people as much as it does to people who are maybe have other motives. You need people, you need grassroots, you need master's and doctoral students who are interested in studying public health policy, and including alcohol. And I wonder what could be done, and I don't know whose role this is, to link with master's programs around the country. Maybe some of you are involved in teaching these, to get students interested. Like, alcohol is one of the most interesting things to study. When you tell people that you're an alcohol researcher, they go, oh, that must be so interesting. You'd say, yes, it is. But lots of the time, if you don't know about something, you don't have an idea what you might want to do for your dissertation. So I think there's potential for more opportunities for people to come on placements from those master's programs. Often, I know in our own university, our psychology students have to do a little research placement as part of their degree. Are there more established institutions and alcohol researchers who could offer those placements? How do we get that sort of, I suppose, critical mass? Of course, people still need supervisors, early career researchers need mentors, and we all learn from those who've been around the longest, and there has been really powerful research leaders in Ireland in the past, but we need to try and get that steady pipeline going, and I'll talk a little bit more about how funding might be able to help with that. But I think it's important also to make the point that at a stage where there are researchers working across different universities and based across many different institutions in Ireland, it's that old cliche, I think. It's not people in different institutions competing for a slice of the pie. It's everybody working together to try to make the pie bigger. So how do you increase the volume of funding that is available for alcohol research so everybody gets to do more of it, rather than sort of working, and I'm not saying this is happening, but I think that there's always a risk of that in the university sector, that people can be secretive about what their ideas are or what they want to take forward. And I just really encourage people to kind of have that sense that, actually, if we all work together, we've probably got a better chance of securing funding than we do if we're kind of competing with each other. Of course, I'm an advocate for bringing people together. There was a joint funding call from the Irish Research Council and the UK Economic and Social Research Council back in 2018, and with Joe Barry, we led the UK Ireland Alcohol Research Network. Now, again, hindered by the pandemic, especially in terms of face-to-face things, but I think just shows what a very small investment can do. We were here just over a year and a bit ago to bring people together for a kind of sandpit, to allow people to kind of think of what their research ideas might be and to think about how they might be able to take them forward. We also enabled face-to-face visits from 3 Irish researchers to UK alcohol research centres. And, we can already see there's been 2 successful funding bids. Frank, who you heard from earlier, has funding for research on alcohol labelling with Anne Campbell, and Grania, who's also here, Grania Kettler, has had funding to bring researchers and community activists together. We're also awaiting decisions on 2 larger applications, one for a fellowship from Susan, who you'll hear from later, and then a collaboration between Northern Ireland, Ireland, England and Scotland researchers on structural separation of alcohol that is at the very early stages of consideration with a UK funder. So of course you need money. I've kind of entitled this in a, I suppose, policy-friendly way, saying how to increase money available for alcohol policy without actually spending any money. I think there's actually a lot that you can do around that. If you can, when you're applying for funding, point to something from the government saying this research is really badly needed and will make a big difference to the policy decisions that we make, that makes it easier for you to make the case that this research is really badly needed and will make it a difference to people's real lives in the real world. But I think there's probably more, and I've only started thinking about this for this presentation. I think there's probably more that can be done. I wonder if the Health Research Board could approach the Public Health Research Programme in the UK, where there's innovation in policy measures in Ireland, where the findings of any evaluation of those would be of interest to the governments of the devolved nations in the UK. And, might there be a way of kind of having a joint funding scheme like the IRC, ESRC one? Are there approaches to Bloomberg, who've just funded a lot of alcohol research in low and middle income countries, and who might be able to might be interested in some of the innovation in policy that's happening in Ireland. Again, I suppose going back to, stuff that's happening anyway, students are writing dissertations, how can we do that? I do think that we also need to look at how we encourage existing funding schemes to consider policy research and how we give that policy research, those bids, a fair shout in those processes. So often in health research, you have clinical researchers who are used to the evidential standards for randomized controlled trials, and they're used to clinical research, considering policy research and natural experiment evaluations, where the standards and what looks like good practice is completely different. It's not that it's inferior in any way, it's just a completely different type of research. But do you have people sitting on those funding boards who are making those decisions who are equipped to adequately compare? You know, if there's clinical research going to the same calls as there is policy research, is that really the right way to ensure that you're getting prevention research being funded and public health research being funded? Because it's difficult if people are not used to those models. I did also, though, feel like I should say, well, actually, alcohol costs an enormous amount of money in harm to the country. So just spend some money on research. It will help to make policy decisions easier. It will improve the policies that we have. And if you do that in a way that focuses on capacity building, it's a really potentially cost-effective measure. So in summary then, if you want to have better decision making, reducing uncertainty in policy decisions. You can't prove everything, but you can make a massive difference to helping to reduce that uncertainty around the likely effect of policies. Then you need a thriving public health research infrastructure for that, and alcohol as part of that. I think you need to commit to the place of research in public health and policy making. I think, you know, it's easy for a researcher to advocate for more research, but I think it makes policies more resilient to being repealed over time in a way that if you don't have that research to back up, it's easy for things to become undermined over time if you've not evaluated things properly, and you can't sort of say, actually, you might think that, but our data shows that that's not how it works. Actually, this is what happened, because we get a lot of myths and misconceptions, as we know, in alcohol, and we get that in relation to policy as well. I would say we need to embrace all findings. We need to be ready to do that, even though sometimes we might not like the findings, but having that grown-up conversation about evidence so that we try to build, I think, better political understanding of what good evidence looks like and how the data works. And I think with MUP in Scotland, I think we have been able to have that conversation where we've been able to say there are lots of studies, they don't all show the same thing, and they're all looking at it from different angles, but we can still synthesize them into an overall picture in a sensible way. And lastly, just to say, it's not a quick fix. It will take time, but events like this are so important, I think, in just building that momentum. And thank you again for having me. And sorry, I am 1 minute over.
Thank you very much, Niamh. That was great. I think the use of a rugby metaphor was particularly nice because it was a really good example about that it's not just about what you say, it's about finding the right way of describing complex evaluations in a way that really resonates and that other people can understand. Probably a good crowd to do it to as well, given Ireland's resounding victory at the weekend, and obviously less said about Scotland's chances of a better. So in that instance, we'll move on to our third and final presentation in this session, which will come from Dr. Zubair Kabir, who's going to be presenting on alcohol policy research, harnessing the global burden of disease data. So Dr. Zubair Kabir was trained as a public health doctor from India and is currently a senior lecturer in public health, advancing epidemiological research and academic public health teaching in UCC and beyond. He is the academic director of the Masters of Public Health program in UCC. He's a lead researcher from Ireland on the global burden of disease study and has published widely in high-impact journals, including The Lancet, Nature, and BMJ as a co-author. He has special research interest in non-communicable disease epidemiology, tobacco control, and alcohol policy, and has recently been appointed the chair of the UCC Healthy Campus Action Group on Drugs, Alcohol, and Tobacco. And he's successfully led both national and international research grants. He is interested in research ethics, data protection, and consenting issues, and chairs the School of Public Health Ethics Committee. And his next mission, a greener tobacco and alcohol-free UCC campus. So Zubair, the platform is all yours. Thank you very much.
Good afternoon, everyone, and that has been a long introduction. I'll echo what Niamh told earlier, so I didn't think that it should be read out, so it got read out anyway. And it's a great platform, as Nathan pointed out, and all the previous speakers. So that's me today over the next 20 minutes talking about alcohol policy research and how do you harness one of the comprehensive data sources we have on the planet, the global burden of disease. So this is a brief outline. Hopefully I'll stick to the time, and I'll quickly give some facts and figures which already have been touched on, both in Ireland and from a global perspective, and what are the data sources, again, that has been touched on briefly, which inform those facts and figures. And then let's spend some time on the global burden of disease study, and then what is the output we had in terms of alcohol research. That's the Irish GBD alcohol study, which we did in collaboration with Alcohol Action Ireland, and it produced 2 master's dissertations, by the way. And then I'll end with some reflections. So this is a piece we got published last year on the eve of St. Patrick's Day in Think Global Health, which is think tank piece with my colleagues in Alcohol Action Ireland, just to showcase the harmful effects of drinking among the Irish youths. Well, it has been touched on, and when I came to Ireland 24 years ago, from different culture and society, I thought alcohol is very much inextricably linked to the Irish society, but things are changing now, the landscape. And alcohol is not an ordinary commodity. We know that, and we have touched on all these figures. It cuts across health, social, environmental, commercial determinants of health, you heard, costing almost 3.7 billion euros. And then the funny thing is that the alcohol industry, you heard a lot from Frank, they're smart enough, smart guys. We need to outsmart them in some ways. And they took undue advantage of the pandemic, and they promoted the deadly poison and investing almost 116 million euros. And unfortunately, the Irish healthcare system is shelling out close to 2 billion euros alone in 2021 to treat alcohol-related illness. And also, just to remind the SDGs, alcohol policies, 13 of the 17 SDGs are very much linked to alcohol policy. There's a framework out there. It just we need action and advocacy. Well, how big the problem is, again, we have touched on this, and the HRB team has been doing fantastic job on this, collating the evidence, producing evidence, and that's where we are at. We saw slides from Frank earlier. The measurement is per capita consumption yearly. We stand at 10.8 liters of pure alcohol. Pure alcohol is equivalent to 1 standard drink, and I don't drink alcohol, by the way, and it's 10 grams of ethyl alcohol. And we are not doing great in Europe, and globally, we have the dubious distinction of having the 9th highest per capita alcohol consumption, and then also the 8th highest rate of monthly binge drinking. So it's all among males and youths in Ireland. That's the area we need to probe more, fund more, do research, and do actions. Again, the recent report published by the HRB showed a marginal decline in the proportion of drinkers between the age group 15 and 64, but we see that half of those drinkers reported hazardous drinking, and they're mostly males and primarily youths. Again, I don't want to dwell on this. This has been touched on heavily here, and we thank the HRB for promoting and producing evidence with such a small, dedicated, committed team. Again, this has been extensively broached on. This is the library, fantastic library. This is the go-to for anybody who is interested in alcohol research, and I won't spend time on this. From a global perspective, the Global Burden of Disease published this in the Lancet, showing the global burden equally worrying that we have 2.4 million premature deaths globally, which are attributable to alcohol alone in 2019. And we have 1.34 billion people consuming harmful levels of alcohol in 2020. And most of them, almost more than 2/3, are among males and also primarily among youths. Again, that's the area we need to tap into, and hopefully we may be able to come up with some solutions. So the global burden of disease, I'll spend some time on this. It's a global enterprise. As I said earlier, that it has the most comprehensive epidemiological databases on the planet. They have 10,000 collaborators to date. When they started, they had only 10 collaborators in the Institute for Health Metrics and Evaluation in the University of Washington, Seattle, in collaboration with WHO, now in 1990. And the beauty of GBD is that they have come up with this standardized methodology, which is crucially important to compare apples with apples. So how we are performing in terms of health and benchmarking. So we need a standard metric, and they came up with these DALYs. I'm sure you are aware of what DALYs are, and it's a distributively adjusted life years, which captures both the premature mortality and morbidity. It's not, we have to move away from the traditional indicators of prevalence, incidence, standard mortality to something which captures both, because we are living longer. It's not whether we are, when we are dying, but also are we living a better life. So that health gap measurement is addressed to this standardized metric. And the second thing is consistency and comprehensiveness. As I said, they have access to, they have cataloged almost 100,000 plus sources in their website. So it's easy to get access to those things, but we can do better. We can enrich them, we can collaborate with them, but the next beauty is that they're all in public domain. So these folks sitting there with 300 researchers, with 70 modelers, funded by Bill Melinda, producing evidence with the techniques they do have. So we don't have to reinvent the wheel. But the thing is that we can have a smart conversation with them, collaborate with them, and exploit the forces of collaborative research, sharing our data with them. So they don't have access to the HRB data. So what can we do then? So to enrich their estimates, to help them out, we need to share the data which we have, which are more at the granular level, and that will produce better estimates. So what they do in each year, they revise the estimates based on having access to this kind of data, more data sources, maybe the evidence has evolved, a systematic review has been published, and they take all this into account in the next iteration. So in every iterations, the estimates are revised. So we can do better, we can come up with better estimates if you collaborate with them and share data with them. As I said, they follow a very systematic and rigorous scientific process. And the estimates are annually published in the Lancet as capstone papers. And because of the pandemic, they have been stalled. Hopefully, the fresh estimates of the latest years will get published early next year. So what they did in this study, which is one of the most comprehensive alcohol study ever done on the planet across 195 countries, published in the Lancet in 2018, the one single message came out loud and clear. So there is no safe level of alcohol consumption. So that's the evidence in 2018. And then what they did again in 2020, having access to more data, they're trying to inform the policymakers how to set their guidelines. So now they have shown that the alcohol burden varies by age. So you see on the top, in the extreme left, that most of the DALYs lost among the young individuals are attributable to injuries, alcohol attributable injuries. And then in the middle slide, we see that most of the DALYs lost among the middle age group is due to cancer attributable causes. And then in the more old persons, the DALYs lost is due to cardiovascular attributable diseases. So the evidence what is emerging now, and we have some discussions to setting the guidelines, setting the limits. I know it's a very complex pathway. We know it has a J-shaped curve, but they have access to high quality data, very sophisticated modeling, so they can pull everything and produce evidence at a global scale. And they're coming up to a conclusion, not yet, that probably we need to revisit our guidelines and have those limits not based on sex, but by age. So as an epidemiologist, it's important that we produce accurate estimates. And for that, we need high-quality data. And as Niamh pointed, it's not having data, but what we do with the data. So we need to share with the people who have the expertise and capacity and resources. If you're not funded, so let's reach out to someone who has the capacity and capabilities to crunch those numbers, the very sophisticated, comprehensive, timely, accurate estimation process. So it's all about measurements, and we can improve our measurements to come out with better estimates so the policymakers are comfortable with the estimates. You can't say, okay, GBD have these estimates, and you guys don't fund us, and you don't take on board the estimates. So it's to work collaborative so that we share our data with them, come up with better estimates. We have our national and sub-national estimates which we are comfortable with, and it can inform policy making. So big data, as you heard, is crucially important to inform policies, and the Lancet paper in 2018 showcased that. And they had access to more than 600 studies with 10,000 collaborators. But GBD has some inherent methodological challenges. Because of the sheer nature of the GBD, they're coming up with estimates across 200 plus countries using the same standardized methodology. So there are areas on the planet where they do not have data. So what they have to do, they have to employ some techniques called crosswalking to produce some estimates. The mission behind GBD is not to have any data, but to have some estimates so that it gives a signal to the policymakers, hey guys, you have to produce your evidence, or at least take on board the estimates we are producing. Again, it's to do with the coding, otherwise called garbage coding, and GBD has the technique how to address those methodological challenges. But one thing is they do not have yet data on socioeconomic groups and also on race and ethnicity, so they are working towards that. Hopefully, they will have data on that as well. So this is the metric they have used, DALY's Disabled Adjusted Life Years. As I said, it captures both mortality and morbidity, mortality in the sense of YLL, years of life lost, and morbidity, years of life lived with disability. So this is the metric which our policymakers should be comfortable with, and we need to kind of educate them so what it entails. And for alcohol, as it is a risk factor, they use the WHO framework of comparative risk assessment. So as I said earlier, that the GBD data are in public domain. So this is the website called GBD Compare. Everyone can get access to that. You can share this with your students, and they can come up with nice, fancy policy briefs with these nice visualizing tools or infographics. And again, some methodological points on that alcohol study. As I said, with each iterations, when they have access to more data and more evidence, and they refine the techniques, and the estimates are revised. So in that alcohol study, they had access to more data sources. That's why they refined the techniques, and one of those is they took account of abstinence in drinking, and also they looked at alcohol-related tourist information and some unrecorded information. But those estimates can be improved further, can be closer to truth if you can share with them the data which still we have access to. They don't have access to HRB data. As I said, I constantly remind that. So we need to work collaboratively with them to produce better estimates so that our policymakers are comfortable with. Lastly, already Frank has mentioned this one. This is the output spin out of the GBD collaborative study, which I'm involved in for several years. So this is Irish Research Council funded project, which was done last year with Alcohol Action Ireland, and 2 MPS dissertations came out of this. As you see that in 2019, we estimated almost over 1,500 premature alcohol attributable deaths. That's almost 5% of total deaths, 1 in 20, as you heard from Frank, and 4 days a day. So that has been cited by a former TSOC in one of the platforms. So it's getting, it's being visible and being noticed. And thanks Sheila, the CEO of Alcohol Action Ireland, to broadcast those findings. And again, they are ranked by the distribution of those deaths by disease conditions. As you see, they are mostly neoplasms and digestive diseases. And again, the proportion of cirrhosis and other liver diseases due to alcohol is almost 3/4 of the deaths. And that's what Frank was alluding to. It's an area we need to tap into. Interestingly, you can also see that almost 27% of the self-harms or deaths due to suicides are attributed to alcohol, and almost close to 20% due to interpersonal violence. So that's an area we need to work upon, and it concurs with the national findings. But we can't forget dialysis. That's what the policymakers should know. They're quoting 4 days a day, but at the same time, they should know that almost more than 5% of the total dialysis lost every year is attributable to alcohol alone. And there is a disproportionate distribution by age groups. So we are losing more than 60,000 dialysis in 1 year because of alcohol. The final thing about GBD is you can rank them. You can rank the conditions between different periods so that the policymakers know exactly where they need to invest resources. So if you look here, based on deaths in 1990, alcohol use disorders, deaths ranked 13. In 30 years, it has gone up to 8. But if you take alcohol as dialysis, then it is the leading risk factor in dialysis lost. Again, this is an output from the GBD. It shows that there was an increase in early 2000 about alcohol attributable deaths in Ireland. And the most worrying part is that we can see there is slight increase in recent years in alcohol attributable deaths. And these are all pre-pandemic. And it's very much mimics the alcohol consumption pattern. They had gone up in 2000. I think Sheila has some points why they've gone up during that period. And now you see at least there's a plateau in most recent years. Finally, some reflections. As you see, 4 people unnecessarily die every day in Ireland, which is totally preventable. And to come up with more robust, accurate, timely, comprehensive estimates, we need to collaborate with people who have expertise and rather than reinventing the wheel. So we need smart collaboration, and the conversation should begin now. Thank you.
Thank you very much, Zubair. That was a really fascinating, but in many ways quite alarming overview of what is a really important and high quality and engaging data source, which really helps set the context and provide us with data which can really help us set the best evidence around that as well. So we're going to have a panel Q&A now. Zubair was literally on a flying visit to us today because I believe he's not going to be part of the panel because he's got a plane to catch, which is a perfectly valid reason. But in terms of a panel, can I ask Niamh and can I ask Marie and can I ask Mary to join me again on the stage? Thank you. Are you happy to stay? Aha. Okay, it's off. Yeah, no worries. Great, thank you. And good panel discussions and QA are very much led by the people on the floor. So does anybody have a question that they'd like to kick off with? Yeah, over in the far corner there.
Hi, sorry, Paul Duff from the HSE. I was just wondering how influential, it was just a question that was running through my head as I was listening to all the speakers. How influential is PPI in relation to shaping policy in relation to research as well? So just a question maybe to Niamh or whoever, maybe to the researchers in the room actually.
Public and patient involvement? Yeah. So in Ireland, I'm not sure what the answer to that is. I guess there's probably other people in the room who've been involved in studies in Ireland who would be able to answer that better. But what we see in the alcohol research that we do in the UK is that it's it's becoming even more important. It was always something that you had to have in your research, was making sure that it was grounded in lay perspectives, both the public generally, as well as, depending on the research, the experiences of people in recovery. That, I would say, has massively ramped up in recent years. So now, typically, when we're putting bids in, and the structural separation bid that Nathan is leading is an example of that, we would have a lay co-investigator as part of the team, fully funded as part of the team, as well as several public involvement panels, as I say, public and people in recovery, quite often different panels, who would be involved all the way through the research in terms of determining the questions, the methods, interpreting, disseminating, everything really. But it needs money. It has to be funded properly. So I suppose the reason that that can be done is because the NIHR, who fund a lot of our policy research, they would normally expect to see at least 10% of the budget spent on PPI as part of a research study. So, you know, typically these studies could be £1 million, so you've got 100 grand of public involvement as part of that, or more.
I can just add that the Health Research Board over the last number of years have become very interested in PPI, in public and patient involvement, and have spent a lot of time and including people on funding panels and making sure people are involved all throughout research, as you said, Niamh. It's a really important aspect. Perhaps Catherine Gill, who's going to speak to us later on from the funding side of the HRB, could speak to that as well.
Great. Yeah, and I'd just add to that as well, we have a number of colleagues at Stirling who are becoming, you know, real leaders and experts in PPI, and particularly in terms of how we design and implement studies as well, when we're designing focus groups or surveys, engaging with the populations that you're interested in really early to make sure that you're asking questions in a way that's going to generate the best data. And I think every time I engage in PPI, it just opens my eyes even wider, really. That's great. Do we have any other questions from the room? Yeah. We'll
More
take those two.
comment than a question. I enjoyed the presentations very much. I think the point about, one of the important points about alcohol is that it's underfunded from a research point of view. And you see that, for instance, at the liver meeting. So half of liver death, half of patients who die from liver disease, roughly, die as a consequence of alcohol. And yet, somewhere between 5 and 10% of the presentations there are alcohol related. So, and there are huge, as John Ryan was saying earlier on, there are huge numbers of presentations about NAFLD, non-alcoholic fatty liver disease, which produces a fraction of the number of deaths. So we have a real disproportion in terms of how research is funded rather. And I think and alcohol research is very, very underfunded. And I think that's a real opportunity for the HRB to think about that. I know I've said that a couple of times today to people here from the HRB, but I do think it's very important to think about. And the second thing that really strikes me in relation to alcohol is that there is a huge amount of evidence about effective measures to reduce population level alcohol consumption per capita. But there's very little implementation, both internationally. You know, we've done quite well here, as I said earlier on, but I wonder, particularly, I'd address this to Niamh, how can we improve in terms of policy making at national levels and policy implementation at national level, given the amount of evidence that we have? I wonder what your thoughts are about that, please.
Yeah, I mean, I don't think there's a quick or easy answer to that, or our colleagues would have already solved it. It's right across the system. Like, so the way that you change policymakers' minds is the way that you change the public's minds. So at the end of the day, politicians are lay people effectively when it comes to alcohol policy, and so they're steeped in the same culture that everyone else is. And so it's just trying to pick away at all fronts. But I think there are some things that we could be better at. And I say this about Scotland as much as about here, and I may be wrong about here, but my sense is that we're not always laser focused as a community, a whole community, about what the policy asks are. So there's loads of things that we're asking for, instead of maybe everybody saying, right, the next, and I think in tobacco they're probably better at this. They kind of go, right, we just got smoke-free public places, now we want smoke-free cars, or now we want some better support for people to create smoke-free homes, or they've always got the next thing, and there might be only one or two of those things, and then the whole community feels like it's pushing for that together. The research is being done. I don't know if we're quite as good as that on alcohol. I think there's very, we still, I think, have that split between people who are most affected and the charities and the people who work with the people who are vulnerable and dependent and what they need, including people with FASD and all of that, and the people who are trying to prevent. And it does still feel like there's a bit of a tension there, because as much as we talk about the severity of the problems for some people, but over here we're talking about the population and that it needs to be population measures, and I think there's a bit of a tension there that we maybe still haven't quite worked out, but yeah, I don't have all the answers for sure.
That's great. Yep. There's a comment just at the back of there. And we could just ask you to introduce yourself before you ask a question. Thank you.
Tom Mangan, Environmental Health Officer. I'm just wondering, is there much research done into post-policy? So to make sure whatever policies are done, are they actually being effective? Because I think it would be an important way to bring the public along with you, maybe to say, look, well, this is what we brought in and this is what we said would happen is actually happening.
Yeah, I mean, there is a lot. So on minimum unit pricing in particular, that came in as a licensing condition in Scotland. So, you know, people like yourself are licensing standards officers who would be going into premises, and they had a role in looking at whether retailers were adhering to the new minimum unit price. And there was a compliance study that was done that interviewed all of them, that sort of looked at the data to see whether people were complying, and largely, you know, compliance is extremely high in terms of minimum unit pricing. So yeah, there would be, I think there's probably a need for more of that. Sometimes when something comes in, there's a bit of a fear around continuing to research it, and you're like, well, we just won that battle, let's not do anything to undermine it. But I think, to go back to what Sheila said earlier, if you kind of have to be able to look at the whole picture or not at all, because if you evaluate minimum pricing in Scotland and you find that it doesn't work, which the data says it doesn't reduce ambulance call-outs, it hasn't reduced road traffic accidents, it hasn't reduced A&E visits, but it has reduced deaths and it's reduced hospital admissions. You have to be able to explain that. So if you don't have some kind of like overarching sense of like why might that be, and I suppose the strongest theory would be that the minimum price itself is just too low, that you see it at a population level but you don't yet see it, and you would see it presumably eventually in cancer and things like that, but you don't yet see it in some of those measures because it's not having a big enough impact for you to see it. But we don't really know. But if a policy is found to not work, it's so easy for it to be undermined unless you know that you can say, well, it didn't work because it wasn't adhered to, it wasn't implemented, or it was watered down. But having data to show that, I think, really helps.
That's great. Any other questions from the room? Not at this point. Well, I'll abuse my chair's privileges and ask a couple then. Niamh, can I ask a question for you first? Is that Helen was saying earlier that obviously there's a lot of interest in what's happening in Scotland now with minimum unit pricing. I wonder if you could just give us a bit of context about where we actually are and what is happening with minimum unit pricing now.
Yes, so it's kind of a moving feast, and you might be able to chip in yourself, Nathan, if I get any of this wrong. But my understanding is that that the stage that we're at now is that all of the studies have been done, they've been synthesised into a report by Public Health Scotland, which has been published. The Scottish Government have also, with that report and in parallel, been engaging in kind of a series of consultations, roundtables with stakeholders, including industry stakeholders, and they're now, I think in the next week or so, going to publish kind of their government report, which says, as I understand it, that they will want to continue with minimum unit pricing, and they'll also at that time tell us what price level they want to set it at. Then there will be, I think, a public consultation on that proposal, to which everybody will be invited to respond. We know what happens with public consultations, that those with the greatest resources are the best equipped often to make the strongest response, so there's a bit of a worry there. But the political parties in Scotland haven't all come out with their position yet. It looks like the Conservatives are not going to vote for the policy, even though they voted for it originally. And the Labour Party have not said what their position is. So I think the thinking is that it's really all on Labour, and if they don't vote for it, minimum unit pricing will no longer be on the legislation books in Scotland. And that's by no means certain. They voted against it originally, so it's in the balance, I would say.
Yeah, it's kind of going back to that question about post-implementation evidence. It's kind of created this new policy lobbying stage. You kind of think the lobbying happens when the legislation happens, and then that's the end of it, whereas actually this is quite a unique situation that we then find ourselves in Scotland. Is there any other questions from the floor? Okay, well, I'll continue to abuse my chair privileges. Can I ask a question of Maria and Mary, in that you quite clearly, from your presentation, do an awful lot to help us in terms of staying up with the evidence and the best evidence, etc. Is there anything else that we can be doing to help you in terms of providing information, staying in contact, keeping you up to date?
Certainly, yes. Actually, I would love to ask anyone here who is actually doing research or knows of research that has been published that we should have on our library. We're always delighted to have input. Our email address is on our website, Drugs Library at HRB.ie. But also, you know, even research you've seen out there that it would be of interest to anyone, please do send it on if you do a poster at a conference like today, because all of that data feeds in to what's useful to people, I think. And we do have quite a range of sources. As I mentioned, we have recorded webinars, videos, you know, under videos, we have audio casts, we have quite a range. You can have them on listening in the background if you're doing something else. So do come onto the library, have a look at what we see, but also please do send on anything you think would be of interest. Because if it's of interest to you, it's probably of interest to your peers. So yes.
We also catalogue PhD thesis and master's thesis, so if they're full text, you can send them in to us and we'll catalogue them on our website.
That's great. We've got a question. Yeah.
This is just a question for the Wonder Women in the library. I'm wondering how you do, or do you have some way of screening out research that's funded by the alcohol industry before you post it? What's the sort of diligence around that? Because it's a creeping and growing piece. Sorry, I was supposed to introduce myself, Paula Leonard from Alcohol Forum, or from Alcohol Forum Ireland. So thanks.
Great. Thanks, Paula.
Yeah, it's a very interesting question. We, as librarians, we're guided by ethical standards of the Information and International Federation of Library Associations, and so priority from their point of view is open access. As we heard a lot around censorship in libraries recently, it's an interesting topic and one we've considered very carefully. As health librarians and as HRB staff, we definitely want to avoid being seen to promote misinformation or purposeful disinformation. So we have to take these things into consideration, even though our remit is to collect and make available all Irish research in this area. I think for us it comes down to the fact that a lot of the people producing this material have a lot of resources. They're going to get their message out. They're going to be on the radio stations. They're going to be, if they produce a piece of research, it's out there. I think we need researchers and advocates like yourselves to actually have access to their research so that you can produce really strong counter arguments. So you can come back and say, well, that's not actually maybe what this is saying. The other point is, if people are accessing the reports of that nature, I think we'd prefer them to come to our site where they can be seen in the context of all the other research that's being produced and in the context of counter-arguments that we can add in as related items in records. And so, yeah, it is a difficult point for us. It's something we'll keep under consideration all the time, our criteria for including items and how we might flag, perhaps, what we see is funded by bias interests.
It's also same around the language and the stigma. When we catalogue academic journals and things, people sometimes say, you shouldn't have used that word. We cannot change the title of an article. It's the author that has written that. We have to catalogue as it is. So.
That's great. Probably got time for another question. Yep, we've got one just down out front. Thank you.
Hi, my name's Katie Dunphy. I'm from the HSC Alcohol Programme. I actually have two questions. One is for Niamh. If the, and yourself, Nathan, maybe, if the MEP isn't brought on in Scotland and isn't continued, do you see that having a knock-on effect on the MEP in Ireland? given that we are so closely following yourselves, and especially around the researching and that side of things, would there be a lobbying for removing it in Ireland or changing it or anything in that area? That's my first question. And the second one was about the point that Paula made there. Is it, or would it be possible, even there was a disclaimer put on some of the alcohol-funded research, that even up in the top of it, that it was, this is funded by, and that might alleviate some of the issues in relation to having it on the site, not having it on the site, but being very open that it is funded.
That's great. Niamh, would you like to take the MUP question first?
Yeah, I mean, I'd be amazed if there isn't lobbying going on all the time to undermine MUP, and I think it's understanding that lobbying is effectively relationship building. It's subtle, it's like giving messages. It's not saying now you should repeal MUP. It's just that kind of creating an environment in which later, if the opportunity arises for you to make a case that MUP should be repealed, that you've kind of got people on side who think like you do, and who think in the way that the, you know, the people that you're working for want the politicians to think. So I think that'll be happening all the time. I would worry very much that if it falls in Scotland, that everywhere else that it's been introduced becomes more vulnerable. But particularly at the moment in Ireland, we don't have any really robust evaluation of minimum unit pricing. You know, the biases study is really helpful, as Helen said, in terms of understanding the impact of alcohol on the hospital service. But the design of the study wasn't able to actually attribute the changes before and after MUP to MUP, just because it happened during COVID and it was post. You know, there was an opening up after lockdowns at the after stage, so or before anyway. So it's messy, but the design just, you can't really actually attribute any changes in those figures to MUP. So we have no data to show that MUP is working in Ireland, which means that we're even more vulnerable, I think, here. If in the context of all that data in Scotland that says that it is working, and it still gets repealed, then that would worry me. But there isn't a sunset clause in the Irish legislation, so it would require new legislation. So, in that sense, there's a protection there. It would be quite a bold move on the part of a politician to say, I want to repeal this. But if you don't have any data to show it's working, you'd be surprised, I think.
Yeah, I'd just add briefly to that in terms of policies, like the principles are the same, but the actual design of Ireland's minimum unit pricing is slightly different to Scotland's in that it's per gram and it's at a different threshold, etc. So that just shows even more the importance of having robust evaluation in Ireland, because the principles is that we should achieve the same effects, but actually Ireland's might achieve different levels of effects just because of how it's been designed. And quickly, Mary Murray, did you want to come back on the comment about flagging industry research?
Yeah, it's certainly something we've considered, so it's great to have feedback from people here to think that's maybe something we'd introduce and be consistent across when we add something like that. Yeah, thanks.
That's great. I have some flashing lights in front of me that tell me that that's the end of the panel. So I bring with you two good bits of news. The first is that it's lunchtime. And the second good bit of news is that while you're having lunch, there are some excellent posters in and around on both the boards and on the other side as well. So please do take some time to look at them and read them. Try and seek out the people who created the posters and talk to them about the research. That would be great. So we have an hour for lunch now. And before we leave, can we thank our speakers one more time? Thank you.